It is now my great pleasure to introduce our next speaker, Associate Professor Raju, who has been in the medical practice for 25 years, including more than 10 years of training in cardiology before commencing specialist practice as a cardiologist and electrophysiologist at Macquarie University and Concord Hospitals in Sydney. He is involved in research into sports cardiology, arrhythmias, and cardiogenic disorders. He speaks on sports cardiologies at premier cardiac conferences, including the European Society of Cardiology, Heart Rhythm Society, and the ESC Preventative Cardiology. Very recently, he was a member of the consensus panel for the 2025 updated international criteria for athlete ECG interpretation. He is a conjoint associate professor and current cardiology clinical discipline head of Macquarie University Health in Sydney. With expertise in this field, he brings invaluable insight into the sudden cardiac arrest in athletes and the importance of screening. Please join me in welcoming Associate Professor Raju.
Thank you. We've already heard just now the really powerful human story that is sudden cardiac arrest and the tragedy that that represents. I'm now going to tell you about the science that explains what happens in this situation and also present some of the data and hopefully leave you with some optimism that we can change this for the future. So sudden cardiac arrest. This is the abrupt cessation of your heart pump because of a sudden development of a life-threatening dangerous heart rhythm. We all know that sport is good for health for a lifetime, but the acute physiologic changes that occur in the adrenergic state with temperature changes, hydration, electrolyte, predispose in that moment the risk of a development of ventricular fibrillation, which is a chaotic, uncoordinated rhythm from what should be normal and regular. And this turns your heart from a powerful pump into useless electrical noise that achieves nothing. And as we've heard, sudden cardiac death is the fatal outcome that follows on if this arrest is not recognized, treated, and reversed. And this occurs within minutes in someone who was otherwise completely well just minutes earlier. So how common is sudden cardiac death? So up here at the top, we have data from Australia and New Zealand and essentially mirrored data from Denmark and Ireland below. And there's a few important messages here. The first is that a significant proportion, the majority of these conditions that affect young individuals causing sudden death are inherited or genetic. And that means that they have implications not just for that individual, but potentially for other members of the community and other members of the family. And overall, it affects a little over 1 per 100,000, and this is sudden death. What about sudden cardiac arrest? The longest standing data comes from a region in Italy, Veneto, who have been doing screening since 1981, mandated there by law since that time. And their data presented over 26 years gives us some take-home messages. The first is that young individuals who die almost exclusively from heart disease. And then the next message is that athletes are 2 or 3 times more likely to have a sudden cardiac arrest than a non-athlete. And depending on the underlying heart condition that they have that is as yet unidentified, that risk can be even greater. We know that in boys, men, that risk is about 3-fold higher than it is in girls and women. And overall, it's probably around about 5 per 100,000 in the young athletes. Everyone knows someone who's had a heart attack, and doctors everyone in the world uses the term loosely, and heart attack in the conventional sense is the commonest cause of cardiac arrest. And that's where you have cholesterol buildup, plaque, blockages in your blood vessels that cause the heart attack that lead to the cardiac arrest. That is not what we're talking about here, or at least not predominantly. The causes of sudden cardiac arrest and sudden cardiac death in young individuals and in young athletes are completely different. We're talking about cardiomyopathy or heart muscle diseases, the majority of which are genetic, that come in a variety of forms, identifiable by testing on your heart. Primary electrical disorders or ion channel disorders, whereby the electrical system in the heart is faulty, but that cannot be identified by looking at the heart, but only by looking at the electrical signals on an ECG. I will recognize here in brackets idiopathic VF, which in doctors' terms means we don't really understand what's happened here. And that is the nature of medicine. There is no perfect test. There are some other congenital disorders, so abnormal congenital, so bypass tracts, so extra electrical connections that people can be born with that can also be life-threatening, called Wolff-Parkinson-White syndrome. And then structural abnormalities of blood vessels in and around the heart. And these, either on their own or perhaps in concert with some other minor and non-specific abnormalities in individuals' heart that may be contributory in an environmental milieu that then can lead to that cardiac arrest event. So, can we prevent it? What does the data actually show? Again, going back to the Italian information that over 26 years. This lists a number of the causes that I've just talked about, but most strikingly, from the time of their initiation of their screening program in 1981, they had an over 80% reduction in sudden cardiac arrest events over 2 decades. That's this line in red, which compares with the line in blue beneath, which is the sudden cardiac arrest rate in non-athletes. More recently, my colleagues at St George's in London and myself have published a more contemporaneous series of over 100,000 individuals who underwent screening by cardiac risk in the young. And this data has shown that about 1 in 40 individuals have an initially concerning evaluation, albeit not diagnostic, of whom maybe 1 in 10, so that's about 1 in 300 overall, are then ultimately diagnosed with a condition that puts them at risk of sudden cardiac arrest. And of these individuals, almost all can be treated to modify that risk with lifestyle modification, tablet treatments, and unfortunately a significant minority, almost half, require some kind of surgical intervention to modify that risk thereafter. But I will acknowledge we do not know everything. Despite best effort, there is still a small proportion of individuals with an initially reassuring evaluation that can go on to be diagnosed with something thereafter. And that's where the recommendation for serial reevaluation comes in. And this means that about 3/4 of conditions that lead to sudden cardiac arrest can be reliably identified. This is a meaningful difference, but it isn't the entire story. And that overall, up to 6 in 100,000 individuals have a sudden cardiac arrest. So when the worst happens, what can we do? This is a picture from 2012, almost 15 years ago, when I was doing my PhD, and Fabrice Muamba, in front of the Tottenham and the Bolton fans in the UK, had a sudden cardiac arrest. And this is a testament to how emergency action can save lives. He had 60 minutes of CPR, resuscitation, defibrillation, and survived with no residual deficits. So why doesn't that happen all the time? there's a delay to delivering this life-changing and life-saving therapy. Why? Because nobody expects a cardiac arrest. Everyone thinks it's something else. And so what should you do? When you see a collapse on the sporting field, then the first question is, are they responding? But regardless, you should be applying an AED just in case, but deliver CPR immediately for anybody who is unresponsive. You will save a life in this situation. People kind of question this because when you have a cardiac arrest, you will see jerking motion, and people think, well, that's a seizure, but it isn't. This is a cardiac arrest. You will see the individual in cardiac arrest have what we call agonal breathing, and their abdomen moves, and it looks like they're trying to breathe, and everyone thinks, well, they must be okay. They are not okay if they're not responding. And the idea that you need to prevent people swallowing their tongue, that's not necessary. Deliver your chest compressions. If there's one message you take away from here today, if you see someone collapse on the field, in the absence of a head trauma, this is a cardiac arrest, and use an AED regardless of what else you're thinking. So, to summarize, in the interests of preventing sudden cardiac arrest and the tragic sudden cardiac death that follows, life-threatening disorders can be detected by screening, and we acknowledge not always, and there is a requirement to commit to a process of serial testing. They are treatable and modifiable. And sudden cardiac arrest is absolutely detectable if you assume that everybody who's collapsed has had a sudden cardiac arrest. And it's absolutely treatable if you react early enough. And so structured screening programs and resuscitation and AED use and training, just as Joshua Hartz is proposing, gives every young athlete the best possible chance. Thank you very much for your attention.